A few words of introduction to Irving Kirsch. I am particularly happy and delighted to have Irving Kirsch with us today. This is not working very well. Is there a different one that I can use?
Yeah.
I guess the batteries are jumping in and out. Yeah. That one. There you go. Do you even need this? I mean, do you need me to use the microphone? I guess so. So, let's start from the end. Irving is coming from the East Coast. He's coming from Harvard Medical School to visit us today. He's a guest of the Brain Institute, the psychology department here at Chapman. Irving and I go a very, very long way, and he's going to tell you some fascinating stories that I started hearing about more than 20 years ago, and I've been working alongside Irving for many years, trying to understand these stories a little bit better and trying to understand the science behind them and contributing to the science behind them. When I met Irving, he was a professor at the University of Connecticut in Storrs, and I went to him to ask him a question about hypnosis. I was doing hypnosis research at the time, and I didn't really know too much about the antidepressant wars and about the efficacy of antidepressants and stuff like that, although at that time I was already working in psychiatry departments, and it was very pertinent that I would know these things. It was all around me, but I was working on very specific things, and this was not part of it. As I started talking to him about hypnosis, I also learned about his major contributions to the field of antidepressants and the efficacy of antidepressants and antidepressant medications. You should know that Irving, as a scientist, is also a clinical psychologist by training. He has degrees from all the Los Angeles area going into USC with a PhD. He's a clinical psychologist who then went into research and has done something that I consider revolutionary in the sense that almost single-handedly, at least initially, almost single-handedly, over time, people joined and started doing similar work, but demonstrated time and again, all kinds of interesting facts about the efficacy of antidepressants for the treatment of depression and anxiety. Irving has impressed me so much throughout my career that in a recent book that I'm working on now, The Suggestible Brain, I dedicate a whole chapter to the work that he's done and how that work has sort of shaped and inspired my own career. Without further ado, I'd like to introduce Irving to you. Listen to this lecture with an open mind. Some people here, like Emma Chen, have heard me talk about this for many, many years, I think. Other people might have known this from the news. It's very rare that we would have somebody of Irving's stature, come and share. He's going to be tomorrow at the Brain Institute at Rinker, for those of you who are interested, and talking about hypnosis and things that are related, placebos and things that are related to this topic, but in an ulterior way. Irving is also a very close friend of mine, and I consider him to be one of my most important mentors and influencers. Some people talk about YouTube influencers. He's my non-YouTube influencer. And he has supported me, not just scientifically, but also personally through all kinds of steps in my career and so on. So it's a special pleasure for me to welcome Irving Kirsch. Take it away, Irving.
Thank you. Thank you. It's a pleasure to be here, especially to be your guest. Come to know and care for Amir and have to hold him in the highest esteem. Makes it a real pleasure. Thank you. I am going to take you on a bit of a historical journey with this. And I'm going to go all the way back to February 26th, 2008. And that was the day on which a meta-analysis that my colleagues and I had done on antidepressants was published in PLOS Medicine. I woke up that morning to see that our meta-analysis had become the lead front page story in all of the UK daily newspapers. 2 years after that, it was a 4-page cover story in Newsweek magazine, and 2 years after that, this.
The medical community is at war, battling over the scientific research and writings of a psychologist named Irving Kirsch. The fight is about antidepressants and Kirsch's questioning of whether they work.
Wow. Somehow, I had become transformed from a mild-mannered university professor to a media-hyped superhero or supervillain, depending on whom it is you ask. How did that happen? Well, I have to go back to first meta-analysis that I did with a graduate student and friend, Guy Saperstein, back in 1998. And at that time, I have to tell you, when we did that meta-analysis, I was not interested in antidepressants at all. I was a psychotherapist. I saw depressed clients in psychotherapy. When people seemed very depressed, I would refer them to psychiatric colleagues to get prescriptions of antidepressants. I assumed they worked. I knew they worked just like everyone else did. But Guy and I also figured, and I got to tell you about it. Yeah, so we also figured that there ought to be a big placebo effect in the treatment of depression. We thought that because one of the core features of depression is a sense of hopelessness. And one of the things people get hopeless about is their own depression. Teasdale at Oxford in London, in the UK, referred to that as depression about depression. So that being the case, if you have the promise of a new treatment that might work better than previous treatments, that might help you, that can instill a sense of hope. And that counters the hopelessness of depression, and people should feel some improvement for that. And we were interested in the placebo effect. And that's what we wanted to evaluate. Assuming there was a real drug effect, there would also be a decent placebo effect. And I've been interested in placebo research. I've been doing it all of my academic career, starting back from when I was an undergraduate student, when I got interested in placebos. So I can't tell you how many decades ago that was. And you might say I've gotten addicted to placebo research. I tried to get the habit. I even joined Placebos Anonymous, where the first step was to admit that I really didn't have a problem at all. But it didn't work. I couldn't stop doing placebo research. And so Guy and I did this study, and we found a nice sized drug response, so people got better when you take the drug. That's important to know. And the degree of improvement that you get is good size improvement. It's meaningful improvement. But what surprised us is that not only was there a placebo response, but it was a very large placebo response. Whereas if you we have also looked at conditions in which people hadn't received any treatment at all. That was important for evaluating what the placebo effect was. And that was very small. The people improved with no treatment, that accounted for about 25% of the response to the drug. Another 50% was the placebo effect, the effect of the placebo over and above improved spontaneous improvement that you would get even without placebo treatment. But that left only 25% as a true drug effect. And that seemed very small for us for something that was being hailed as a revolutionary new treatment for depression. So we published these data. We titled the article, Listening to Prozac, but Hearing Placebo. And it became very controversial. One of the critics wrote that our analysis was flawed, that it derived from a minuscule group of unrepresentative, inconsistently and erroneously selected articles. And this was one of the first meta-analysis I had ever done. Very first meta-analysis. This was the second one that I participated in. The very first that the guy had done. And I have to admit, we did not do a very good search. We would never do it like what we did back then. And so we took that criticism seriously and decided to see if we could replicate it with a broader series of studies. Where are we going to get the broader series of studies? We used the Freedom of Information Act. And we asked the FDA to send us the data files that they had, summary data files, on what at that time were the 6 most widely prescribed antidepressants. Now, the FDA data is very important for a number of reasons. First of all, it's the basis for drug approval. So if you argue there's anything wrong with these trials, which people do, they say, oh, the FDA trials that the drug companies do for the FDA, they're not done very well. If there's anything wrong with these trials, the drug shouldn't have been approved in the first place. They're supposed to be adequate and well-controlled trials, and the FDA requires and that they get all of the trials that the drug company has done, whether they were published or not. And that's important because it turns out that 40%, almost half the trials, were never published. And if you look at the data, you can see why. If you look at the published trials, 3 out of 4 studies reported significant results. If you look at the unpublished trials, only 12% reported significant results. By going to the FDA, we got the data, the aggregate data, from all of the trials, the unpublished trials, as well as the published trials. And we analyzed those. And what we're looking at now is the most widely used measure for assessing antidepressants, for assessing depression, the Hamilton Depression Inventory. And we looked at people who had been randomized to get the actual drug. We found a 10-point difference. That's a reasonably decent improvement. But we found over 8 points improvement in the group that got placebo, leaving a drug placebo difference of less than 2 points on this 53-point scale, a scale that goes from 0 to 53 points. That's statistically significant. But the question is it clinically meaningful, that difference between the drug and placebo, that 1.8 points? So I need to explain what the difference is between statistical significance and clinical significance. Statistical significance looks at the question of whether an effect, how likely it is to be a real effect, how likely it is to be just due to finite, just due to randomness, chance findings. It doesn't tell you how large the effect is, what kind of difference it would make in someone's life. And that's what clinical significance looks at. How large is the effect? How much of a difference would it make in someone's life? Let me give you an example. Let's imagine we did a study with 500,000 subjects. And we learned that smiling increases life expectancy by 10 seconds. Now, with 500,000 subjects, I can virtually guarantee you that that 10 seconds difference due to smiling is going to be statistically significant. How much meaning does it have? Practical meaning. So here we are, we're looking at these drug placebo differences. The National Institute for Health and Clinical Excellence, the acronym is NICE, This is the outfit, very nice organization in the UK that establishes treatment policies for the National Health Service in the UK. And they propose a criterion for clinical significance, and their criterion was a 3-point difference or a 0.5 standard deviations, effect size, standardized mean difference of 0.5 as a criterion for clinical significance. And as you see, the difference we found doesn't come close to that criterion at all. So we published those data. And the critics said, it's a nice criterion, it's a nice criteria to the 3 points and the 0.5, and that's arbitrary. And you know, they're absolutely right. It's as arbitrary as using 0.05 as your level of clinical significance. That's just a conventionally adopted arbitrary criterion. We say that a response to a medication is, we usually say that 50% reduction in symptoms, that's what they always say for antidepressants, that would constitute a response. Arbitrary. So what would a non-arbitrary criterion look like? What might it be? From the area of pain management, there's a consensus that has been reached on what constitutes a clinically important reduction in pain, and they do that by looking at the comparing scores to the clinical, it's called Global Clinical Impression Scale. That's a scale, and they said in order for someone to say that the pain reduction is meaningful, they should be much improved. This is a scale in which clinician rates the person as being very much worse, minimally worse, not having changed at all, minimally better, much improved, or very much improved. And pain researchers suggested that you should have reached the level of much improved in order for it to be clinically meaningful. And when it comes to depression, there is an analysis that have been done looking at studies in which they measured both the Hamilton Depression Scale score, which is what we had been looking at, and they also had data on how much improvement the clinician said the person has made. And here's what they found. In order to get those people who were evaluated as not having changed at all, their improvement on the Hamilton was 3 points. People with an average score of 3 points were rated as not having improved at all. You got minimal improvement when you reached 7 points improvement, much improved ratings at 14 points. Oops, sorry, that's the wrong button. At 14 points and very much improved 20 points. So you can think about which of those might be a criterion. Certainly 3 points should not be a criterion because that's something that clinicians see as no change at all. Then the critics replied to that by saying, well, the patients weren't depressed enough. So we took another look at our data, and we reanalyzed it looking at initial severity. How severely depressed were the patients at baseline? We found only one trial with moderately depressed patients. That was an early trial of Prozac. No difference at all between drug and placebo on that trial. After that, they stopped including mildly depressed and moderately depressed patients in the clinical trials altogether. In fact, there weren't any trials with people in the severe range. All the other trials involved people in the very severe range of depression. And taken all as a group, again, their depression scores, the difference between drug and placebo was very low, below the 3-point level that would indicate no change, let alone minimal improvement or much improvement. When you're looking at drug placebo difference, what is the drug doing chemically? It's doing close to nothing. There was one small group of patients that showed scores as part of that 1.86 improvement, that showed improvement beyond the no change level, but well below the minimally improved level. So we published that study. And the critics, that was in 2008, and the critics said the patients were too depressed. I guess what they meant by that is to point out, they said, look, there were no people who were severely depressed. They were all very severely depressed. In one study where they were only moderately depressed, maybe it's in the severely depressed but not very severely depressed people that you're getting an effect from the antidepressant medication. They were hypothesizing a curve like this. I call that the Loch Ness Monster hypothesis. Said, well, maybe some people benefit and some people don't. And you know, I think they're right, because I've seen two studies, only two studies I could find where it seems to make a substantial difference. These were studies done by Kim Hunter and her colleagues at UCLA. And they did two different studies, and they found a group of patients that you can see over here that both studies, beautiful replication, both studies, people that are, here's a group of people that show no drug placebo difference, and another group of people that show a modest drug placebo difference, one that is well above this 3-point criteria suggested by NICE. What was the difference between these two groups of patients in these two studies? The difference depended on whether or not they had had prior experience with antidepressants. People who have never taken an antidepressant showed absolutely no difference between the drug and placebo. Those who had had antidepressants before, it should go to this, that's the one that's being filmed, yes. Those that, no, I guess not. I'm looking at that little box down there, that's why. Those that had had prior experience of taking antidepressants, they showed a difference, although they did not do as well as those who had never been given antidepressants before. Why? Why did that make a difference? Here's my guess about it. You not only get the treatment benefit, if there is one, you also get side effects. And in drug trials, you know what the side effects are because they part of informed consent. They have to tell you. You may get drug, you may get placebo. If you get the drug, these are the known side effects of the drug. And so, if you know you're getting the drug, you're going to get a better response than if you know you're getting the placebo. Oh, I can't be getting the drug. I know what these antidepressants feel like. What's the implication after treatment? I think the implication of these data are you should never give an initial prescription of antidepressants. It's not going to do anything beyond the placebo effect. Do everything else first. Critics' last resort is what I call the true believer hypothesis. Very famous professor of pharmacology in the UK wrote, "Antidepressants work. Everybody knows they work." That was his argument. Another critic wrote, "Millions of content patients can't be that wrong." Well, let's look at some of the treatments that have worked for millions of content patients throughout the history of medicine. So, one example would be cigarettes to cure asthma. And they wrote that it was a permanent cure. Universally recommended by the most eminent physicians and medical authorities, and it's harmless and may be safely smoked by ladies and children. Then, of course, there was Bayer heroin, made by the same company that invented aspirin. They were the first to have synthesized heroin from morphine. They were selling it as a cough suppressant, over the counter, of course. And did you know that 7-Up used to contain lithium? The same drug that's used to treat bipolar disorder. And they said, "Hey, Greg, why we have the youngest customers in the business. Nothing does it like 7-Up." And we go earlier into the history of medicine. They used treatments like lizard's blood, crocodile dung, pig's teeth, etc., etc. And that's why we don't use anecdotal reports for judging whether or not to approve a medication. We do clinical trials. And when you do clinical trials on antidepressants, everyone gets the same results. Everyone. After we published our meta-analyses, a number of other people did meta-analyses. Some of them to see if they could replicate it. Some of them convinced we were wrong. They were going to do it right and show how wrong we were. And here's what we have gotten, this 1.8 difference between placebo and antidepressant. And here's what was found in various attempts at replicating it. Everyone gets the same results. And I want to call your special attention to the last one on that list. This is a Stone analysis. This was an analysis done at the FDA on all of the data ever sent to them for what eventually became approved antidepressants since 1960. More than 73,000 patients in 228 clinical trials, and they had the raw data. That's something we never had. They had the raw data, so this is what they call a patient-level or pooled analysis, patient-level meta-analysis, where you're reanalyzing the actual raw data on 73,000 patients. That ought to give you a pretty comprehensive, reliable end to the discussion, and what you'll see is they got the exact same drug placebo difference that we had done in our small meta-analysis, a difference of 1.8 points, even to the second decimal point. Roger Lieberman, after the Roger Lieberman? Jeff Lieberman of the American Psychiatric Association, after the 60 Minutes article, said, issued a statement for the American Psychiatric Association saying that Kirsch's conclusions have been discredited widely by the FDA. Oh, I wish they would discredit my work more often, given what they reported. Here's what the head of psychiatric drug approval that we did in 60 minutes before he fired now. Here's what he had to say about it. And having a hard time getting that to work. I didn't try the videos out on here.
Well, the first one worked.
I don't know. Anyway, here's what he wrote. He had should be a video with sound, but I can tell you the one sentence in there. He said, "We all agree the difference in improvement between drug and placebo is rather small." Tom Logren, the director of the FDA Division of Psychiatry Products, 2010. They're small. To not see how small they are, you have to bury your head in the sand like an ostrich or a drug company sales rep. And it doesn't matter which antidepressant you take. We went back to our data and we looked at, well, SSRIs, most commonly prescribed antidepressant, NDRI, tricyclics, benzodiazepam, found a trial of benzodiazepam for the treatment of depression. Head-to-head comparisons. Response rates, how many people met that criterion of 50% reduction. As you can see, no difference. No differences in those. Those are virtually identical. And we have to look at one more antidepressant, and it's called tianeptine. As I said, the most commonly prescribed antidepressant type is SSRIs these days. Tianeptine is an SSRE. It's a selective serotonin reuptake enhancer. It's supposed to do in the brain exactly the opposite of what SSRIs do. How well do they work? Just the same as any other drug that's used for antidepressants. Well, maybe you have to have different drugs for different people. Maybe some people have a deficiency and they get depressed because they have a deficiency of serotonin. Maybe others have too much serotonin. Maybe others have a total condition. It's not serotonin, it's something else that's doing. And you have to look at that. And one way you deal with that, you give someone an antidepressant. It doesn't work. You switch them to another antidepressant. See if maybe that will work. There are some clinical trials looking at that. They tell people they may be switched now, they may not be switched now. Some people are double blind. Some people are switched to a different antidepressant. Some are kept on the same antidepressant. What happens? You've got people now who haven't responded to an initial trial of the antidepressant. You switch them. You now have 34% new responses to the antidepressant that you didn't get with the first one. Get remission, score of 8 or less on the Hamilton Depression Scale, which they say means no depression. 18% reach that criterion. And then you look at the people who are randomized to be kept on their original antidepressant. 40% are now responders, 20% are now remitters. It doesn't matter at all which antidepressant you take. And if you switch from one to another, the only difference that can make is one, spontaneous improvement, two, a placebo effect of thinking that you're switching. You're getting a different drug or maybe. What do you call pills, the effects of which are independent of their chemical composition? I call them placebos, and my friend and colleague, Amir Raz, has pointed out that they should be taken with a grain of salt. So how should depression be treated? What should we do? Well, antidepressants it's not the chemicals that are doing it, but it is producing a reasonable amount of improvement. So maybe we should prescribe antidepressants in order to get the placebo effect. We would call them use them as active placebos. An active placebo is a drug that has no chemical effect on the condition being treated, but is an active drug. Does, for example, present side effects. Well, the problem is that you have to consider the risks of antidepressants as well as their benefits if you're going to use them, knowing that the chemical is not having a beneficial effect, is having risks. What are those risks? Are they worth it? Well, we have side effects like sexual dysfunction. Sexual dysfunction has been reported for between 70 to 80% of patients taking antidepressants and SSRIs, specifically SSRIs, lower rates with some of the others, 70, 80%. Weight gain, long-term weight gain, insomnia, diarrhea, and so on, many others, and addiction. Antidepressants are habit forming. Among people who try to quit, 50% fail, 55% report withdrawal symptoms, 27% say they are addicted to the medication. Then there's a problem with suicide. The FDA issued a warning on suicidality and antidepressant effects, which are printed on the drug labels now, labeling information that come with the drugs. Here's some of the data on that. They usually talk about that. The FDA talked about that, and the initial warning was involved people who were being prescribed antidepressants who were kids, adolescents, young adults up to the age of 35, that they were the ones that showed these significant increase in suicidality. Here's a meta-analysis looking only at the adult data. Suicides on antidepressant and on placebo, attempts, antidepressants. I have it backwards on there. I'm sorry, antidepressants tripled the risk of suicide. I've got to check that slide. Sorry about that. Then critics said that this FDA warning has decreased the rate of prescription of antidepressants, and this would increase the rate of suicide. So Mark Stone at the FDA looked at their data on suicide rates and compared suicide rates to the percent of the population using antidepressant year by year. And what you see with young males and females, you get a really super high correlation. The more antidepressants you prescribe, the greater the rate of suicides. And the same thing happens with that black line going down. That's when the black box warning was put on. You saw prescribing went down, went back up again. Suicides went down, went back up again right with it. Again, different ages now, all the way up to between 65 and 74 years of age. The the size of the correlation in most of these studies was above 0.5. So these are substantial correlations between suicidality and antidepressant use. In this case, actual suicides and antidepressant use. So what can we do? Well, antidepressants, as we've seen, show a benefit over placebo, a very small one. We want to at least match or exceed the placebo rate. Doing nothing doesn't work. People are put on waiting list controls, that may be in part due to a nocebo effect for being on knowing you're on a wait list, because you can't do that double blind. There is a way you can do it actually, usually very rare. But you don't get much improvement there. Standard care, about the same as the placebo effect, even though that usually includes medications. That's the standard treatment after. Psychotherapy. Psychotherapy plus antidepressants. When the raters are blind as to which group the person was in, you get very little difference, you get non-significant difference. Exercise, acupuncture, omega-3, homeopathy, Tai Chi, Qigong, and yoga, all of them produce responses comparable to those that you get taking antidepressants. That's the short-term outcomes. Let's look at the long-term outcomes. This is a meta-analysis of studies in which people were given psychotherapy, usually 15 to 20 weeks, behavioral therapy. Most of the studies were given placebo, given antidepressant pills, and both are then discontinued. And then you see what happens in terms of the long term, looking at after some time after you've discontinued it. And these are meta-analytic studies, and what you can see is those who have gotten the CBT are doing significantly better than those who have gotten and discontinued them from antidepressants. What about if you just discontinue the psychotherapy, but let the people in the antidepressant group continue their antidepressants? What happens in the long run then? Here you go. People who stop their antidepressants do not do as well as those who have had psychotherapy and stop their antidepressants. So does cognitive behavior therapy, because that's what's measured, assessed in those studies, does it protect against relapse? And that was the initial hypothesis and the way people explained those data. But there's another possibility. And I first saw this other possibility by looking at this study in which they randomized depressed patients to three groups. One group was given an SSRI, citalopram. Another group was given a physical exercise program. And the third group got the combination of both the exercise program and the SSRI, antidepressant. In 4 months, remission rates looked pretty damn good in all three groups. No real difference, no significant differences between their remission rates, 4 months, but high rates. Then they looked at relapse 10 months later. How many people relapsed? In the antidepressant group, 38% relapsed. In the exercise group, only 8% relapsed. But what happens when you combine the two? Exercise and SSRI relapse rate is back up to 35%. Adding an SSRI quadrupled the risk of relapse. What you get just having physical exercise. There's another study looking at that in panic disorder. Comparing imipramine, cognitive behavior therapy, and the two combined. Relapse from imipramine, 40%, CBT, 17%, the two combined, 48%. So, and here are relapse rates from a meta-analysis as a function of what kind of treatments they got. SSRI, SNRI, these are the relapse rates. And those in the placebo groups in these studies, there's the relapse rates. And those who improved on their treatment. So it's not that CBT inoculates against relapse as much as antidepressants, when they are discontinued, have a long-term effect of increasing the likelihood of relapsing and becoming depressed again. So, should we prescribe placebos? Well, the problem is, we assume that in order for a placebo to be effective, you have to know, you have to think and believe that you're getting a real drug. As this patient says, if I know it's a placebo, would it still work? Well, there's some interesting answers to that that we don't have time to go into today. Any of you who comes to my lecture tomorrow will hear more details about whether or not you really do have the high effect that it's placebo. But I want to tell you another possibility right now. And this comes from the work of Niels Baga in Denmark, who has been using imaginary pills in psychotherapy. Here's how he describes it. I've tried giving clients imaginary pills, either red, blue, or green, in a suitable size for the effect they want. And I try to build an expectation of the effect. Usually they feel the effect of calmness or trust or depression lifting slowly as we sit there. And I instruct them that now that they have experienced the effect, they can take a pill whenever they want to. When therapy is finished, I often ask clients what they found to be helpful during their time with me. To my surprise, they often mention the imaginary pill as being among the most helpful. So we don't have to prescribe placebos, but I have to tell you, I wish we could. As I mentioned, I love placebos. When I was living in the UK, I had a dream one night. My dream, I awoke, but this is just part of a dream, and I opened my favorite morning newspaper. It was called The Independent, and that's the title. And I read that placebos had been approved by the FDA in doses ranging from 1 to 40,000 milligrams. And then I thought, here in the US and in New Zealand, the only two countries that permit this, we do advertisements on television and newspapers for drugs. I'm sure you've seen them. You have this young woman skipping through a field of flowers, and the voiceover, I used to be depressed. And I thought, well, gee, wouldn't that be great? If FDA approved placebos, then we could advertise them on television. And I wondered, what would a placebo advertisement look like? I think it might look something like this. Prevaricaine, a genuine placebo medication, tested in more clinical trials than any other treatment. So powerful, it's the standard by which other medications are judged. So effective, it can be used in the treatment of thousands of ailments, and safe enough to be given to infants, the elderly, and pregnant women, just like asthma cigarettes. Remember, if it's a placebo, you can believe in it. And I thought I might conclude by reading a poem of Shakespeare's. But then I thought, why should I? He never reads any of mine. Still, I can't resist reciting to you Shakespeare's Ode to Placebos. It's a placebo. Friends, colleagues, placebos, spare me your tears. I come to praise placebo, not to bury it. The evil doctors do lives after them. The good is often part placebo. The medical world's a stage, and placebos merely players. Each one plays a different part. This one Prozac, that one morphine. The winter of our discontent is made glorious summer by these sweet placebo pills. And nothing is real, but thinking makes it so. And I thank you. Oh, questions, comments?
Any questions for Irving? This is the perfect time to ask. All right. Tomasz.
Thank you very much for the talk. I have just a quick question. So we saw that the clinical significance is really not there, but there is still a statistically significant effect. So as you said, the effect is indeed real. So what would you attribute that effect to?
And again, I would attribute that largely to breaking the blind. So imagine you're in a clinical trial, and they tell you, you may get the real drug, you may get a placebo. You and we don't know which it is until after the trial is over. But you should know, if you get the real drug, here are some of the side effects that you might get. Very common, dry mouth. A list of side effects that I show you, some common ones on one of the slides. Then you give your pill, you're wondering, what am I getting? What do I get? Do they give me the drug or do they take the placebo? Oh, my mouth is dry. You didn't bring any water.
I did, but
My mouth is dry. Wait a second. That's one of the side effects. I've been given the real drug. Hooray! I feel better already. It's a small extra benefit. Could very easily. One of the things we know from studies, when you ask patients and doctors in drug groups and placebo groups, psychiatric drug groups, psychiatric placebos, what they think they were given or what they think their patient was given in the trial. Both patients and doctors are very accurate in the drug condition. In the placebo condition, the patients are less accurate, but the doctors remain very accurate. And in 3-arm trials where there are 2 different drugs, they can even tell you which drug they got. They're supposed to be double blind, but sometimes double blind turns into double talk.
Thank you very much.
Erica?
Yeah, thanks for a great talk. So I have a couple questions. One, what in the studies you went through, what's the main dependent variable again? Maybe you said it early on, I forgot. What is it?
Hamilton scale for depression, Hamilton rating scale.
So it's self-report, not the clinician.
No, it's more often clinician. The Hamilton rating scale is a scale that's filled out by the clinician rather than by the patients. One of the things, reforms that I would like to see in clinical trials, especially for mood disorders, for anything that involves a psychological outcome, is I was going to say
Hamilton.
that they should assess both clinician and patient.
So they don't ask the patient how you feel?
They ask the patient, how do you feel? And then that's part of what the doctor uses to decide how much the person has improved.
Right, but I mean, the patient doesn't fill out the question.
Right, things like the Beck Depression Inventory, which is a patient-rated scale, are rarely used in drug trials, rarely used, and never as the primary outcome. So the primary outcome in depression studies are almost always, in the antidepressant medication studies, are almost always physician-rated scales, the Hamilton being by far the most frequently rated There are some others like the Madras is another one. I won't try and remember what it's an acronym for, but that's where those are all physician-rated scales.
It seems like that would be really interesting to know. Is there any, I mean, because I'm left with this other question is, well, are they good for anything? It's hard to believe that something that has such a profound effect on a major neuromodulator system in the brain has nothing but some side effects and no, like, is there some cognitive enhancement? Is there some plastic? I've heard that fluoxetine reintroduces plasticity and ocular tolerance columns in B1. Like, does it do something?
Well, first of all, the scale that they are using most often, the Hamilton and also the Madras, they don't just measure how depressed does a person feel. They ask, there's 53 questions. So they ask about sleep, they ask about eating, they ask about the whole range of things, suicidal thoughts and so on. And those are the ones that the clinician then rates on the scale and they do that. They have not found on symptoms of depression any difference. Now, whether in a total, if you're trying to treat something entirely different, what happens? They are real drugs, and they do have effects. They're just not beneficial effects for depression. And for the various symptoms of depression in various ways that we think of it.
Okay, thanks. Thanks very much.
Thank you for speaking. I just was curious because you kind of talked about the placebo effect and all these things happening. What would you suggest for, let's say, a loved one or yourself personally taking antidepressants? Do you think that maybe this points to the fact that maybe it's more mental than physiological in some ways, or is it, is there like maybe some suggestions you can give? Would you suggest people still go their CBT route and go these antidepressants? Could you speak on that maybe?
Yeah, so if you're already on antidepressants and you're not bothered with side effects and you feel the beneficial, I'd stay on them. If you're on antidepressants and either you are bothered by side effects or you would just like to get off them, then the option is to taper. Some people can get off very easily. Some people have to taper for a couple of years. And to get out, there are websites that help people taper specifically from antidepressants. How do you get the dosage right? And when you get to the point, so beyond the lowest dose pill you can prescribe, how you can get that little by little, because some people need that in order to get off of them. In that sense, they're similar to benzodiazepines. You can become addicted, not in the sense that you're craving it, but in the sense that you get withdrawal symptoms that are intolerable to you when you try to quit.
All the way from Vermont, Marie-Christine wants to ask a question.
Just add that if the person's never been prescribed antidepressants, then I would avoid them and try everything else first. If you use them at all, it should be as a last resort when other things either haven't worked or the patient won't accept taking other things or doing these other things. Then, perhaps.
Okay, we have one question from Marie-Christine, and Tian is going to give her permission to ask. He needs to set that up. Any other questions from here before we go? Yeah, go ahead, David.
Have you or anyone else that you're aware of thought about, since tapering came up, I was wondering during the talk, about sort of a combined antidepressant placebo where, the pill would be designed in a creative way that you'd get a very low dose for the first 3 or 4 weeks, and then the taper would begin, and with each refill, you get more and more sugar and less antidepressant. Sort of to jolt the system and make some side effects, but very briefly. I mean, it's kind of a dumb idea.
I don't think it's a dumb idea at all, because this is a problem that people face. they need to taper very gradually, and there's no way to get down to that level easily, and they have to go and learn these complicated techniques for.
Oh, I've been there.
So
Not for myself, but for a family member, yeah.
So yes, if at least they would manufacture something that would make that possible to do, that would be a great boon. I don't think they have any motive for doing that.
They'd have to make a deal to charge the full amount.
But also, they don't want people to get off them.
Right,
And this is
yeah.
going to help them get off it. I remember when NICE did their report in 2004 and did their own meta-analysis. They came to me and asked me to consult with them a bit, give them some of the data that we had, which we shared with them, all of that. And they told me, and they actually changed the treatment recommendations in the UK based on those data. And they told me that they had wanted to get a hold of the data comparing genders, males and females, on different antidepressants, because they had this hunch, I forget which was a tricyclic and which was the SSRI, that one of them worked better with males, the other worked better with females, and again, I don't recall which was, and this was their hypothesis. They wanted to check it out. They asked the drug companies to either do the analysis, report the results, or send them the raw data, and they would do the analyses. None of the drug companies were willing to comply with that. Not in their economic interest. Why comply? And this was a governmental agency in the UK that's trying to set treatment policy for the whole country.
Marie-Christine, s'il vous plaît.
Thank you, Mayor. We're getting, and thank you so much for your talk. I appreciate it. It's immensely needed. As a clinical psychologist trained in different countries, including one that has socialized medicine, I'm curious what you think about the social and economic determinants of what is an effect that goes way beyond inertia in science, continuing on this trend of prescribing antidepressants, but rather qualifies as obscurantism and obstinance. I wonder if you have seen different cultural contexts lend themselves to a more critical evaluation of the same type of results that you're bringing, and what your thoughts are about exploring these questions in a different socioeconomic cultural context.
Well, looking at them in different cultural contexts, they're worthwhile to do. That's perhaps more worthwhile for understanding the placebo effect than understanding anything about the drug effect, because I can't say, I'm just saying this is a layperson making a guess, but I would guess that if there's no physiological curative effect of the medication in one culture, there probably isn't in another culture, but the placebo effect might differ a lot. The way in which depression is diagnosed may differ a lot. We know that he was in Japan. They didn't even, when they started marketing antidepressants, they didn't have a word for depression. And they made a new term, which literally means blue fire, as I can recall, is the meaning of the term. But that was for marketing purposes. But yes, looking at other cultures, I think is a very worthwhile thing to do in dealing with depression and other mood disorders.
Any other questions? Go ahead.
This one is just a quick clarification question. When you are talking about the relation between antidepressants and suicide, we saw the relatively high medium-sized correlations, 0.5, as an incidence of time between antidepressant prescription and suicide rate. Is that is the effect of incidence of depression accounted for in that correlation? Because when you have higher incidence of depression, of course you prescribe more antidepressants, and of course you have more suicide rate. So that's just a clarification.
Yeah, and that's a plausible hypothesis. But remember, there are other data too, and that's just looking at the rate of suicidal thinking in people who have been given the antidepressant versus people who have been given the placebo. in clinical trials. And we know that that's a significant difference for people up to the age of 35. And we also know that if you're just looking at adults of any age, sometimes it reaches statistical significance, sometimes it doesn't, but there's always, in all of the meta-analyses that have been done on this, greater suicidality in the drug group than in the groups that have been given placebo. And by our logic of looking at drug effects, that would suggest that these do increase suicidality. That's consistent with the time data that you saw. The time data has another possible explanation, but that doesn't address the difference between suicidality in people who prescribe antidepressants versus those prescribed placebo.
So I understand that people might need to go, but I'd like to just continue the conversation a tiny bit longer. And at some point, if people want to stick around, Irving and some of us are going to go get some lunch. But I just want to continue a tiny bit longer. Most of you, I think, appreciate well that as commonplace as depression is, it's not possible to diagnose depression with a brain scan or a blood kind of test. Right? I mean, diagnosing depression is an art form, really, a clinical art form, where there's some kind of a Chinese menu that you have to go through, and you have to see like certain symptoms over time, and so on and so forth. It's sort of weird in that regard that we have a phenotype that is so dominant and is so, debilitating for millions and millions of people. There's a weird consensus on how you diagnose it, and now you're showing us that there's also weird consensus on how you treat it. What should people, maybe in this, lecture hall, maybe listening, what should they think about, if they are on antidepressants, if they know people who are antidepressants, if they have family members, friends, what should they be thinking about what to say to them, what to do about it, having listened to your lecture?
Yeah. Again, if your friends, loved ones, acquaintances are taking antidepressants, they're pleased with the effects, they're not having side effects that are bothersome, I wouldn't say anything to them. If they want to get prescriptions for someone in their family who's not been prescribed them, then I would talk to them about why maybe trying other things would be a better strategy than using antidepressants, if anything, as a last resort, if at all, as a last resort. But for the person who's already on it, it's a different story. Someone who does want to get off them, I would be supportive. And the thing I'd be most concerned with is tapering well in order to avoid withdrawal symptoms. Now, some people don't need to taper. So, you get withdrawal symptoms in around half of the people that take antidepressants. You can get it even with relatively short-term exposure to antidepressants. I would avoid even, let's take it for a while and see what happens. And the long-term outcomes aren't as good as other things. But once you're already on it, it's a different story. You don't want to just get off it like that. If you're going to get off it, this is what I would say to someone, a loved one, someone I cared about. You want to get off it, you need to do it in a way that doesn't cause withdrawal symptoms. If you're happy with what you're doing and it's working for you, continue doing it.
Now, a lot of young people particularly, but people in general, and I think that particularly students and people who are high school students, college students, and so on, have experienced the whole pandemic period in a, I would say, in a catastrophic fashion, in the sense that, social circles have been cut, the ability to communicate. We feel that, and it's something that we see, an impending tsunami of, mental health basically coming to our shores as sort of waves of repercussions coming from all the social distancing, all these things. Things are beginning to look better now in terms of the virus, but in terms of mental health, I expect, maybe you disagree, maybe you agree, that the prescriptions for antidepressants are just going to grow in the near future and so on. Is there an ethical, a moral, a scientific responsibility that we have to take this information and communicate it not just to doctors, to therapists, to people who are prescribing these drugs, but also to the public?
Yes. Yeah, I think we do. And I think it's useful for the information to become well known. People who are taking the family members who are on antidepressants and have become family members relatively recent through partnerships and close relative partners, and so they get to know my work as well. I know one who's been on Lexapro, which is story about Lexapro is a little funny too. Has been on Lexapro for many years, and at one point she decided she's going to try and get off it. Got in touch and says, "I tried to quit. I can't. I can get there. I've got these withdrawal symptoms," and so she has to stay on it.
Any other questions?
I have a question regarding the Danish pills that you mentioned at the end.
About the what?
The red group pill. So basically, when you tell patients that what they are getting is placebo,
Yes.
how much of are there trials going on? Is there anything telling us how much of the placebo effect is retained?
Well, that's a very interesting question. Tomorrow I'm going to be talking about that because there have been about 15 trials internationally done now on using open label placebos for various conditions. We found significant results, and some strong results actually, in treatment of irritable bowel syndrome, chronic low back pain, chronic rhinitis, test anxiety, a number of different conditions. In those studies, we give people placebo. We tell them this turns out to be critical. We tell them that it's placebo, that there's no active ingredient, but we also explain to them how the placebo effect is very potent in this particular condition, whichever it is that we're looking at. And even if they know that they're getting a placebo, it may help them because of this phenomenon called classical conditioning, which everyone has heard about, Pavlov and the dog. And just as Pavlov's dog learned how to salivate in response to the sound of a bell, we have had so much experience with active, effective medications that we've come to associate the pill, the capsule, the injection with improvement in our physical conditions. So we tell them all of that. We and others have been involved in a few of these studies, but it's been done now internationally and replicated on different conditions. We tell them that, and then people are randomized to get the open label placebo or just get whatever treatment they've been getting, treatment as usual. And we get, within just 3 weeks, we get substantial effects favoring the open label placebo to no treatment. Substantial clinically meaningful, statistically significant from the treatment as usual group. We have now published a 5-year follow-up on patients with chronic low back pain who were given a open label treatment compared to treatment as usual, and for those in the open label placebo group were told to continue taking their medication. The only difference we're going to add on the open label placebo, got a substantial reduction. 5 years later, they maintained their gains on both pain and disability. And whereas before the study started, 87% of the patients in both groups were taking anti-pain medications, were taking pain medications for the chronic low back pain. They were doing that during the 3 weeks of the study. At the end of the 3 weeks, the control group was offered, and almost all of them took the open label placebo for 3 weeks. 5 years later, whereas beforehand 87% were on pain medication, only 30-some% were on pain medication 5 years later. They decreased their pain medication, the pain levels were down, their disability was down, and their benefits remained for 5 years of follow-up. So we're excited.
Great, thank you.
So Irving, the last thing I wanted to ask just before, we call it a day here, as you know, there's a trend among people who are interested in psychedelic substances to replace some of the antidepressant materials, SSRIs, sometimes other benzodiazepines and so on, for the treatment of depression and anxiety with either small doses, not so small doses of psychedelic drugs such as psilocybin, LSD, and so on. And there are all kinds of anecdotal reports. It started with anecdotal reports. Now we're beginning to have New England Journal of Medicine studies showing that these are very effective and so on. And given, how, I don't want to say ineffective, but given how effective SSRIs are compared to how effective placebos are, maybe that's, a new way forward in terms of helping people deal with their depression, anxiety, and so on. Do you have some thoughts about the model of SSRIs for depression versus the model of psychedelic drugs in depression and treating depressive-like symptoms?
Well, I'm going to limit it to psilocybin because those are the only data that I've seen on it, the magic mushrooms. And one of the things that I know in all the studies where they have been compared to evaluated in terms of the response for depression is they always include psychotherapy. It's a session of psychotherapy that is done during the psychedelic experience. So it could be, I have no way of knowing, it could be that psilocybin increases the effectiveness of a single psychotherapy session. My hypothesis, my guess about it is that you see, experience, feel things with psychedelics that are very, very different than anything you experience without them. It changes your perception of the world. I'm a preacher of was a young man in the 1960s, so I will confess that I speak of that from previous experience from decades ago. But you would never in advance be able to imagine how different for the universe it seems when you're on a psychedelic to when you're not on a psychedelic. And that might expand your sense of what is possible, of how much of what you experience in this world is potentially malleable and how your experience can change. Maybe. That's a guess that may make the single session help people to see things in their own depression in a different way. But I think it's a worthwhile exploration. And again, as far as I know, there's no evidence that taking the drug without the psychotherapeutic context has an effect. And so maybe what's being done to help people interpret that experience they're having in a way that's beneficial to them in dealing with this.
You're not just an expert in antidepressants, you're also an expert in suggestibility. Do you think that there's a possibility, a realistic possibility that taking psychedelic substances could change someone's suggestibility either temporarily or permanently, and then what you're seeing is a change in suggestibility profile that would allow certain suggestions to penetrate and create changes?
Maybe also, one of the things that we know is that different placebos have different effects, and the more powerful an intervention is non-clinically. So for example, placebo injections we know are more effective than placebo pills, and sham surgery is much more effective than placebo injections or pills. We know that, and just the thought of a psychedelic and what it does, and then the experience of it to reinforce that it really does do something dramatic, that might be working as a suggestion effect. Very possible.
Any other questions? Okay, thank you very much, Irving. That was fascinating. Thank you so much.